Welcome to Public Comment. I'm John Dunbar, former mayor of Yountville.
And I'm Alfredo Pedroza, a vintner.
And I'm Amy Herold. I have a lot of jobs. I've been limited to the first 6. I'm the Chief Medical Officer at Queen of the Valley Hospital. I'm the Chief Administrative Officer at Queen of the Valley, which is our version of the CEO. And I'm an OBGYN physician and a student and a wife and a dog mom. Made it.
There it is.
We don't get to choose the illness people come to us with. We just have a hospital and an ER, and that's what we do.
If one of these hospitals is not here, the county suffers.
St. Helena Hospital as a rural hospital was listed for closure, which is complete bullshit.
Alfredo, what have you been up to?
So many things, John, but I think you want to be very specific on what you're asking me. And I think you're asking me about my little simple house addition.
Yeah, I'm wondering if it's on time and under budget.
It wasn't, but look, I wanted to go through the process just like everyone else. And we had an architect, we had a general contractor, and while we were quick, the process did teach me a lot. I think there are moments where the county did really great, and it wasn't great because it's me. It's great because you had great customer service, right? They understood that. But I'll tell you who wasn't great, PG&E. And I tried to be kind. I wanted to promote them for all the right reasons, but they are absolutely a siloed organization. They don't understand who their customer is. And quite honestly, I don't think they care. And to me, that's the hardest part, John, where you have people within PG&E that I think it's almost they take joy in saying, you know what, we're not gonna be able to do it. It's gonna take 6 months or 8 months, and we might be able to do it, and then they have no concept of time, they have no concept of budgets, and that's really disappointing because I was with PG&E, John, and you know that, right? When everyone was bashing them for the power shutoffs, when everyone was suing the shit out of them, I was like, no, they have a hard job. And I still think they do. And we know their CEO, right? And we didn't go to them because we wanted to go through the process. But the fact that you have people within that organization that almost take joy in saying no, it's hugely disappointing. And if I could go off the grid, I would, because I do not want to be a ratepayer for PG&E.
How do you really feel?
I already said it, John. But it's the fact that they're the only game in town is mind-boggling. They have a monopoly. And guess what? They should do better because we do pay the rates, which pays their salaries. And you just have people in that organization that have no pride in the work they do. I'm done.
Well, you know what? Save that energy. Let's go inside and talk to our guest.
All right.
Alfredo, we are in the presence of royalty today.
A
A doctor, absolutely. A chief administrative officer, a chief medical officer, a dog mom.
Yes.
A spouse. Wife.
New wife.
I missed one.
Congrats. That's awesome.
Thank you.
Well, welcome.
And a student for another month.
Because you don't have enough degrees yet.
Correct.
John,
Okay.
I feel you're underachieving right now.
Yeah, I feel like I'm underachieving.
So where should we take this?
Wherever you'd like. Thank you for joining us, first of all. I know that with all that you have on your plate, incredible that you have the time to come in and chat with us, us two misfits. But thank you for doing that.
Whoa.
You're welcome. It's because I like your wives.
Yeah. I knew
They are assets.
Yes.
That was going to be a line. I was just waiting to see when Amy was
It
going to
didn't
drop
take long,
that. So
did
that
it?
was well done. But I think you and I talked about healthcare, John. It's one of the topics that I think we've been interested in, Amy, because it's hard, right? You know, we've talked about business.
Dr. Amy to you.
Yes, sir. She should diagnose you because there's a lot of issues on that side of the table. But, you know, we've talked about business. We talked about regulations. We've talked about wine. But healthcare is so critical to life, especially in Napa County. So I think when we first met, you were at Queen of the Valley, right?
Mm-hmm.
Was it during the pandemic? I don't remember.
I've been there since 2015, but I think I met you during the pandemic.
So how was that? Like just, you know, from your side, kind of maybe a trip back down memory lane. How was it like being in healthcare during that moment?
It was insane. I was the incident commander during the pandemic. So basically I was the incident commander for about 1.5 years straight. And it was one of those things that we just got our team together every day and said, we're building the plane as we fly it. Nobody knew, especially when it first started. We didn't have treatments for it. We didn't have vaccines for it. We didn't know much about how it was spread. It was very scary. And we got those first 2 patients from the Diamond Princess cruise ship in Japan. We had some of the very first patients in the US in our ICU.
Yeah, didn't they isolate that ship in the Bay, San Francisco, or
I
no?
think that was a different one. They isolated it in Japan, but then they flew the Americans back to Travis Air Force Base. And 9 people on that flight that were originally negative turned positive on the 19-hour flight. So they needed non-military hospitals to take them. And because we're close and we have an isolation unit, we took 2.
Well, and I think
Wow.
what Amy just said about, you're flying the plane, that's what we did in public office, right? Because there is no playbook on if this happens, you do this. But there was so much criticism, there was so much expectation on the healthcare system that it was hard for all of us to try to digest. And there was a lot of doubt, a lot of, conspiracy theories, but it was like, you're trying to do the best you can.
Right. And it was on Nextdoor, I think. The phrase of you shouldn't
we
drink.
gotta drink.
Every time next
Cheers.
doors,
You did it.
Cheers.
We-
I did
It
it.
used to be general plan, but season 2 is next door. As you were saying.
Yeah.
I almost want to say it again. This is delicious. Thank you. You should never read the comments. We all know that, right? On any of the social media
Very
pages, don't read the comments. So I had a team of folks that we asked for volunteers first before we made anyone. And we had a team of people that were really brave. It was all the full suits, the isolation, the uncertainty of, are they going to put their families at risk?
That's a good point, though, because I don't think people
going home and
what that meant to people.
what were you
like
bringing with you?
Yeah.
Well, I mean, some people, my ICU doctors got hotel rooms and didn't go home because they had young kids at home. So people sacrificed a lot in those early stages. But I read a comment that said, I can't believe they brought people with COVID into Napa. I hope everyone at the hospital gets COVID and dies. And I was just thinking at the time, I'm like, I have people that are so brave. Even you think about housekeepers and the people that deliver meal trays. The housekeepers have to go in and clean those rooms. And that is not the highest paying job at the hospital. And look at the risk that they're at in this situation where we just don't know a whole lot. So that comment hit hard, but that was the comment that kind of galvanized me to be like, okay, we're going to figure this out together. We did it during the fires. We've done it during a lot of things here. Napa is a community that I will be honest, I'm so proud to live in because I'm like, we just figure it out as we go. And I'm like, I don't know, we'll try it. And we had meetings every day. I'm like, we're going to try this. If it doesn't work out, if there's not a problem, we're going to meet again at the end of the day and let us know. We'll try something else.
But that was also, you didn't have enough staff, of course, because you're all working like round the clock, literally, in multiple days. And some people, like you were talking about, not going home for the fear of the unknown and the fear of the known about the spreading of the disease. Didn't have enough ventilators for the really sick folks. And we were dealing with the uncertainty from a different perspective about policy and
Politics.
mask wearing and 6 feet of distance.
Well, I remember, John, like we had a couple of knuckleheads, right? And for me, what I said is like, look, we're all trying to understand what that was going on. But if our hospitals are full, we're shutting it down. Like at the end of the day, that was my measurement. Like I agree. There's so much misinformation. But if we don't have a bed for someone in our community, that means we have to take action to make sure we're minimizing.
Remember, the county was counting the number of beds and talking to all of us in the jurisdictions. Is there any room?
Yeah.
And every day it was like, we got 4 beds. We got 10 beds. We have 0 beds. It's like,
well, then we threw the fires of 2020 into it when St. Helena was damaged.
Yeah.
And then that was the Delta surge. We didn't have vaccines yet. And now we've lost one of the hospitals in the county. That's when things got really tight and dicey. And that was an interesting one because we accepted all the COVID patients from St. Helena and then a significant number of their patients in the first evacuation. But then after that, nobody had anywhere else to go. So they all came to the Queen. And people were retiring. They were calling out sick. We lost 40% of healthcare workers nationally during COVID.
40%?
40%. And so we're running short. Our census is going up. And in the state of California, there's ratios on how many patients per nurse you can have. And we're like, we have beds. We don't have nurses. And we have people stacking up in the ER that need a bed. And so we called the state and said, can we go out of ratio? And they said no. And we said, well, can we get help getting travelers? Because we couldn't find travelers. They were all deployed everywhere and they couldn't find us travelers. And I thought,
so the traveling nurses.
They're traveling nurses,
And that's something that I didn't realize even existed until that period. And it was its own, sector.
Well, and then the markup on the traveling nurses was so high, it would have cost us almost $1 million a week for 10 people, nurses and respiratory therapists, $1 million a week in our little community hospital to pay for
But
that.
I will tell you though, Amy, because I think that stat there is so critical, right? That there's ratios that you did go to the state to ask for exemptions. Because the one thing I learned during this was there was so much misinformation.
Mm-hmm.
And then we're trying to compete with providing the truth and being transparent with information. And there was so much emotion that everything was getting charged and things were getting weaponized. So, I think if we go through this again, I think one of the lessons learned is how do you try to have direct communication with the public as much as you can?
Mm-hmm.
Because you had friends, you had messengers that were in public office that could help, that could weather some of the hits, right, from the knuckleheads. But if you don't have those messengers that are on the team, then you're behind, right? And that's what concerns me about community, because public health is part of community.
Right.
One of the additional hurdles was HIPAA and patient privacy.
Mm.
And then here I am in Yountville and you're with the county and we're trying to get individual jurisdiction information, and there were limits to what could be shared. And it was frustrating from my perspective because we're trying to take care of our local population. And I get that the county needed to do what it was doing, but that's an example of where there was a lot of friction because it was so unclear. The rules were changing almost daily.
Mm-hmm.
And,
You're
we
tier
were,
one, remember that, vaccines.
well, we were on calls. I know, because I was with the League of California Cities. I was the league president in 2020.
I'm going to drink to that.
And
just
there you go. I brought it back up.
I know you did.
Come reach
Yeah.
me with my T-Rex arms. I
Yeah.
have to get in there a little closer.
But we were hearing from the state and from the national crisis folks, public health people, and things were changing constantly. And so for you to be in that role and having to absorb so much and all of the other people that you were working with, it's exceptional. And the fact that we don't remember it as clearly as we should every single day, because I know you do.
Mm-hmm. Yeah. Well, I'm so incredibly proud of my team. I'm proud of the people that were brave and stood up and said, we're here for healthcare. We don't get to choose the illness people come to us with. We just have a hospital and an ER, and that's what we do. And so people can come to us with anything, and it is our jobs to take care of them. And it's why we're there, is that's what we want to do. But we had some outpatient programs, our physical therapy department, some other things that were closed. So they got together and made a crafting table, and they made us masks and shields and all the things when we didn't have enough PPE. I'm like, again, that's why I love being in Napa. I'm like, we literally had a crafting table made up of physical therapy, occupational therapy. And we had restaurants and community workers that were holding signs on Wednesday that said, honk if you appreciate healthcare workers, or bringing us lunches. And so there was a lot of things that were really positive too. We all remember, I love your word, the knuckleheads.
Yeah.
But there were some really strong folks in there. And so that was the best part of it.
I want to ask you, and this is kind of backing up to how you started in the medical field, because this wasn't what you signed up for.
No, I'm an OBGYN.
You're
I deliver
babies.
babies.
Yeah.
And all of a sudden, I'm the lead person. They wrote a policy at our system level. We have 52 hospitals that said, in the case of scarce resources, when they have to be allocated and decided, the final decision maker is the chief medical officer, meaning we have 2 patients, 1 vent. I am the one that has to decide who gets it. And I remember reading that and thinking, well, how in the hell am I responsible for that? I'm an OBGYN. Like, I did not sign up for this. But my ICU doctor looked at me, and he's so smart and was working so hard. And he's like, we just need someone to turn to. Will you please be that person? I was like, all right, well, here we go. Also the part where I started anxiety medication. Thought I was okay and had really bad dreams that people I knew were coming in. They all needed ventilators and I only had 1. But we weathered through that. And we did come to a point where we ran out of vents and needed some, but our Providence Hospital in Eureka had some. So on New Year's Eve, one of my biomed guy got in his car, drove up to Humboldt, grabbed us, can't remember, 5-10 ventilators, put them in his truck, and came back New Year's Day so that we didn't have to run out.
Right. Well, and also it wasn't that long ago.
No,
it really wasn't. And, human nature, we put, compartmentalize things and move on, like with the fires. But this was different. nobody understood what to do.
But I think I think we've developed some muscle memory, though, just like the fires, though, John. I think the first one, 2017, was harder. Granted, the one in 81 we don't remember. But I think people are remembering that, right? And trying to develop the institutional knowledge that gets housed in public health, that gets housed in government agencies. So we're better off, right? To me, one of the questions is I'm a Queen of the Valley baby, by the way.
Did I deliver you?
I don't know. I could ask. But the whole.
That would be very talented on your part.
Yeah,
but I would not put it past you.
But, for someone that's listening to the podcast and they say they hear about Kaiser, they hear about St. Helena, they hear about Queen of the Valley, what does that mean for Napa? Because I tend to think we're freaking fortunate to have all these institutions in our community. But tell us a little bit more, Ian, from your perspective of what's that like and how do you guys work together? How do you partner and so forth?
And the special services that you provide too,
Good
that
point.
we might think that they're available at all medical centers, and that's not true.
And that's not true. To answer your question first, what I love about being here is we do have those, but we are a smaller community. Again, we work together. So Jennifer Yasmoto at the county brings us all together quarterly.
And she's the director of
Health and Human Services.
Perfect.
And so we have leadership from Kaiser, from St. Helena Hospital, me, Partnership Health Plan. I don't want to miss anybody. Alicia's there. And we get together and we talk about issues that matter to all of us and who's doing what, where are we investing our money in the community? Are we all investing in the same thing? Should we be looking at other places? So that was very helpful. It was called our Leadership Roundtable. And over the past probably 6 to 8 months, it's taken a bit of a turn with HR1 and the big bill.
Yeah.
I can't even say it.
Yeah.
But when we look at that and the cuts on healthcare and what that means to Napa, in my hospital and Steve Herber at St. Helena, both of us have 70% government payers between Medi-Cal and Medicare.
Wow.
Kaiser, not so much. And Ole Health is 100%. So, and then Partnership funds those. So we've gotten to a point where now we're looking at if we're really going to lose funding for this many people, if we have this many people losing their insurance access, what does that look like? Who's going to pick up what? So then to your point, John, there's some things that we used to do at the Queen that we have to look at right now. And we're contracting our services just a little bit to make sure that we have the funding to pay for the people that are sick, scared, our core business at the hospital. And then taking a look at what do we have other partners in the community that are doing that we may not be able to afford it right now. Hopefully we will in the future, but and we're all looking at programs like that. But what I love about Napa is we're looking at it together and saying, if we have to pull back from this, is there somebody else doing it so it doesn't leave a gap in the community? And I went to LA for 2 years and that didn't exist down there. In LA, all of these things felt very transactional. Here it's our heart.
Sounds integrated.
It is. And and you look at us on the surface, we're all competing industries, but when you get down to it, we're all here in healthcare and everybody's like, we don't want anyone to go without services. So who can pick up what?
Well, that's what I was about to say. And you said it first and I'm sure better, but with St. Helena Hospital, they're very impressive and they provide some very specialized services as well. And there probably is some competition. It might be with staffing, funding, things like that. But when it comes to the healthcare piece, there's no hesitation. Mm-hmm. You help each other.
Yeah.
And that's to our benefit.
Yeah, absolutely. We took their COVID patients we took all their patients when they evacuated the first time. We took the really sick ones the second time when it was really serious. They've loaned us equipment when we're like, we need this. Something in the OR broke. Can we borrow one from St. Helena? They'll loan us stuff. So Kaiser during the fires send over a big shipment of N95s because our UPS or FedEx driver would not drive into the valley because it was so scary. So Nor over at Kaiser loaded up his assistant's car. Let's drink to Nor.
Nor would want to drink.
Nor we're drinking tea right now.
Oh, the N95 masks.
He just loaded up a car with a bunch of them and had somebody drive them over to us. So
see, those are the stories that make you proud, right? To be in Napa that I don't think the public gets to hear all the time. But to your point about some of the challenges around federal funding and state funding, when you look forward, is this sustainable, Amy, though? Or what do you think is going to happen? Because Napa is so used to this level of service. Mm-hmm. And that's the concern I have. The county of Napa was blessed that in some counties, they have their own hospitals. And we were very clear, we don't want to be in the hospital business, but they're not a direct funder. And I'm not saying they should be, but I think if there are gaps, I think that's an honest conversation people are going to have in this community. And I just don't know how that happens.
Well, and I remember I did a tour for a new county supervisor in, 2016, I think. And their comment to me was, well, you're the county hospital. And that still sticks with me. I'm like, we are the biggest hospital in the county. We're the only trauma center.
Yeah.
We're the only labor and delivery. We have a lot of the only services in the county, but we're not the county hospital. We get no county funding, but we take care of everybody, whether you can pay us or not. And that's part of the mission. But that makes it really challenging to keep the doors open when we look at our normal payers cutting reimbursements significantly.
Well, and I'll tell you, I'll say, because I thought about it when I was on the board, is I do think the county has to look at a direct investment, right, into healthcare, because it's a proactive investment, right? And if one of these hospitals is not here, the county suffers. There's consequences in a very real way. So you do not want the county operating hospital. That's my opinion only. So if you don't want that, then you have to make it proactive investments. So I think that's just a healthy conversation to have in the future, right? Because again, if we want these outcomes, then how are you investing to see these outcomes?
Well, I know everybody that's been paying attention should have been very alarmed when they saw that St. Helena Hospital was listed on potential for closure as a rural hospital that somebody decided was not necessary, which is complete bullshit. We know that. And that's scary also, today's climate and how it's managing or mismanaging healthcare, and that's a whole nother conversation about funding and Medi-Cal and Medicaid, Medicare. I got a necessary but still challenging education in all the different funding sources when
super complicated.
Yeah. And most people can't afford to navigate through that stuff, and people don't realize it. And it's one of those things where you don't know anything about it until you're forced into it because family is in the middle of it. And that's what I went through. And it took so much effort to just learn the system. And meanwhile, you're trying to make decisions to support a loved one.
I know you're talking about.
And it's frustrating. That's the easiest way I could say.
Yeah.
Well, I got a question, and it's kind of off the wall, but so I go to Kaiser, pay some wonderful premiums or whatever. But I also look at healthcare as like, if I'm healthier and I'm not going to the doctor, that's better. Right. But I know this much about healthcare because I was on the board for Ole Health. And I remember how you have triggering events that you have a specific reimbursement rate, but it seems a little archaic though, Amy. And I have my monthly bill that I pay to, Kaiser, whoever. Couldn't there be a different way though, right? So shouldn't it be the healthcare provider's interest to keep me out of the doctor's office, right? That means they're a more efficient system. It made me, John going to the gym a little bit more, so I was healthier. But isn't the goal to
That's why I drink wine, dude.
I was going to say, Fredo wants you to go to the gym, John.
Yeah. So I'm just trying to be mindful, and I want you to keep doing this for a long time.
Be right there.
That's a good line. But I guess the whole point of healthcare, right? Is there an opportunity to look at it differently, Amy, than how we look at it? And I know that's big picture discussion, but
it is, but it's a discussion that's been going on for a while. It's the difference between paying fee for service, which means you come to the hospital and the hospital gets paid for fees, versus value-based care, saying we look at this as a population level and we pay you based on quality outcomes, keeping people healthy.
Is that happening now?
It's been in transition for years, but the problem is it's less than halfway there. So you have some value-based contracting where your goal is like, I have almost 19,000 capitated lives in Napa County, meaning we function as their home hospital and get almost like a Kaiser per member per month for these. And we work with Ole Health. And they come to the Queen when they're sick, and Ole Health takes care of their outpatient needs. It's better for everybody if those stay out of the hospital. And so that's a great opportunity that we have with Ole to partner.
But your incentive model and how you get paid
is a per member per month. And so that's what you get paid. And if they use the hospital, that's already been paid. So it's capitated to us, and that's an already paid for.
Wouldn't the incentive be, though, that the less they go, the more that we should all be incentivized so that way they're not using your system and creating capacity.
Yes. So it is an incentive for us and Ole Health. So
To keep
we
them
work
out.
together to keep people healthy.
See, I like that. I think that's the future.
I love it. And I think that's why Ole Health has some of these really cool programs that keeps people healthy that a lot of people with private insurance don't have. So again, the problem is it's there halfway. And so you either have to go all in or all out because it's really tough to do anything where half of it is done this way, half of it's done this way in parallel programs. But it's kind of like the Kaiser model where everybody pays in and everything's included. So it's in everyone's best interest. And we want people to stay healthy and not need the hospital. But then there's access issues. People are scared to go for preventive care right now for
multiple reasons.
And so they're coming in a lot sicker.
And I get that, right? To me, it's just acknowledging, the way people are living today is different, right? When I was growing up, we couldn't wait to be outside, running around, be on a bike. And I look at how my kids are growing up, it's so different. And I want to make sure that the systems in our community are incentivizing them to live healthy. But you don't have that necessarily, right? So the more structures we can put in place to incentivize that, that's kind of I hope we get into that direction.
Where accountability-based care and value-based care becomes more than the fee-for-service where you're sick and here you get paid. I agree.
What is your capability, if you have it, for mental health services? Because we're certainly hearing a lot of that, especially I thought of it when you were talking about children, young people, and we're really hearing a lot more and more about the struggles that the generation that's growing up on devices with social media, with all those pressures. Is that something that you're able to provide at the Queen? And if not, what?
Or just the topic in general.
Ish. So we do the medical clearance for behavioral health. We don't have an inpatient psychiatric unit at the Queen. We do have telepsychiatry. And Napa County is weird. I'm going to take a quick step back. We've had people come in and do needs assessment, like how many doctors do you need based on the population and the age? Like how many cardiologists do you have? How many do you need? What's the gap? So we've done a gap assessment for these. And we're always considered on paper to be flush with behavioral health and psychiatry. They're like, you don't need anyone there because they're counting Napa State, which nobody else has access to. But on paper, we look fantastic. But that's the forensic and, so we always have to level set. You can't count that. We have such a desert of behavioral health here. So Providence has a telepsychiatry where we can do visits with a psychiatrist. But we don't have inpatient psych. We don't have it anywhere. Sinalena may have a few beds actually, but it's not something we have in the county. We have to send out to bigger hospitals outside of the county. So we have 6 beds at our crisis unit to hold people. They have 1 or 2 adolescent chairs, and we are seeing more adolescents that we're holding in the ER. And we hold them until we have a safe place to put them. But in ER with the bright lights and it's mayhem, especially in the middle of the night. No, and if you're already suffering from a behavioral health crisis, that is not the environment we want to keep you in. But we can't admit them to the hospital because then you can't transfer out. There's all the EMTALA and transferring rules. So we have to hold in the ER. And we're seeing a lot more of the older population where they have cognitive deficits and in addition to the behavioral health. And so a lot of the behavioral health facilities won't take them because they say, well, there's a brain reason why they have that. It's not just mental health. So it's really hard for geriatric psychiatry and it's hard for adolescent psychiatry because there's only a few beds. So that is a huge gap. But given our aging population and just there's no adolescent beds anywhere, that is a challenge.
You were to look at me when she said aging population. I just had to get in front of it because that's what he would have done.
No, I wouldn't. I think this is a really great topic, John, because we've talked about it. And I think, how you started there are issues that we're seeing in our community, right, around behavioral health, mental health, right? The wellness centers that I think are in some of our schools are phenomenal. And I remember the Education Foundation was kind of cutting edge of trying to institute these at a time when people were saying, well, we don't know if they work. I'm like, well, I'm willing to find out, right? You put them in the schools and you found out it worked. And we've all said, let's spend $2 there versus $5 on the back end. But I think as a community though, Amy, and that's why I'm interested in mental health, behavioral health,
Mm-hmm.
I still think we're having a hard time coping with it, right? And then there's cultural issues that we haven't even talked about. There's so much there. And I just don't know if we have the systems in this community to start making the difference that I think we need.
Yeah, I think behavioral health is a huge gap for us here. Memory care.
I'm looking at you now, John.
I'm ignoring him right now.
I see that. You're
I'm
like
sorry.
intensely ignoring him by staring at me. It's a little odd. But I all of a sudden have 3 teenage boys that I didn't have prior to July. So Brock has 3 teenage sons, and I see the same. It's devices, it's video games, and a little bit more withdrawing.
Yeah.
And
that's the point that the withdrawing from society structures, right?
Yeah. I see my own niece and nephew and the increase in anxiety, especially during COVID with the isolation. And we don't have great programs here.
Go ahead.
I was just going to say, I just saw a national news story yesterday about how teens are going back to shopping malls, not so much to shop. It's to socialize. And so some malls are adding activity spaces so that they just basically respond to that trend. It's interesting because we've got a couple generations now that grew up with, tablets in first grade and iPhones at birth. You probably have iPhones or some kind of
the birth
mobile.
center?
Yeah. As your congratulations, it's
Swipe.
a boy, girl, and here's your iPhone 17.
Yeah.
Reference to your new phone.
As
It's not shattered. But it's just a different phenomenon that the response to the phenomenon is, of course, slower than the need to respond to it. And hopefully there'll be some solutions.
Does that mean hot dog on a stick is making a comeback?
yes.
Corn dog, probably.
Yeah. But hot dog on a stick specifically, best corn dog ever.
Yeah.
Only
Come on,
found in
John.
malls.
Not just during the fair.
Those are pretty tasty too.
I don't know that John really understands the significance of hot dog on a stick.
John,
I can't say that I do.
Have you ever been to one with like the women that look like they're 6 feet tall and wearing the multicolored hats and all they do is
Yeah,
make corn
and they
dogs
have
and lemonade?
lemonades.
Best lemonade.
See, John.
I guess we didn't have those in Oakland.
Oh, yes, you did.
Oh, John, you need
Just-
to go to a mall.
We're going to bring it back just for you, John.
Thank you.
But in terms of going back to healthcare, right, and how do you adjust to mental health, is there discussions, Amy, around how do you try to stay ahead of it, right? Because I look at the demographics, right, of Napa. We are getting older,
Mm-hmm.
but then you're also seeing, a good young population, and within the Latino community, a positive birth rate. Those are potential issues, right? And sometimes it just seems, are we reactive? And that's the way it has to be, or can we be proactive in something like this?
I think we need to be proactive. I'll tell you the reality is I feel reactive. I feel like we're trying to keep our head above water just to
I
keep
agree.
the services we have afloat.
Because of all the different pressure points.
Because of, and we've just talked about reimbursement issues, but then we look at costs. I mean, the seismic regulations for healthcare centers. We had a quote 5 years ago that to get our hospital we have one wing that's not seismically compliant. To get it there is $280 million. And that was about 4 or 5 years ago.
It's gone
So
up.
my guess is
Wow.
let's double it based on tariffs and labor costs and everything that we've seen increase. And that's due by 2030. So we're trying to move all the services we can out of that area. But that's a huge burden that is weighing on us of how do we do that? Do we build another wing? Do we make it more compliant? Building another wing, again, like $500 million to spare is a heck of a bake sale.
Well, is there a way to solve some of these monumental problems locally or regionally, or does this really need to be like a federal program, for lack of a better word, to either fund it or change the requirements? Or, I mean, there's no way a local, especially nonprofit hospital is going to have $200+ million set aside for anything. So how is that resolved? Is it statewide, national?
The seismic, it's only statewide. It's a
Right,
California
but I mean,
requirement.
those kind of significant
right.
challenges, that's just one of them. The seismic thing in California is different than other parts of the country, but
Right.
there are some common major hurdles, I would think, that other hospitals and medical
Can
centers
I
are.
add something to that,
Yeah.
John? Because you've listed a couple of things. Could merger or consolidations be part of that solution?
I think everybody's looking at those types of answers right now of where does it make sense? Who has a completely non-seismically compliant hospital? Is it better to abandon it and merge with somebody else rather than rebuild something smaller. Because as you said, we're focusing more on keeping people out of the hospital. So you don't need as big of health center of acute care hospitals anymore. Maybe you need bigger active wellness centers and wellness and fitness areas. So those are conversations that are in play, but the timeline is coming up. And as you guys know, even just construction requirements in California, for us to build something, I need a cardiac cath lab. By the time we get the permit done, maybe 3 years until we get it built because of all the things that go through, not just California, but then the healthcare system within California, OSHPD and HCI. So it's very expensive. It takes a very long time. Yeah. So we're trucking along. But to, again, go back to your question is, are we proactive in this? We are to a point. We meet with the county stakeholders. We do a needs assessment. We know that housing, affordable housing is important. Behavioral health is important. Access to food is important. Like these are the things that are important for the healthcare in our county. But how proactive can we be in all of them? In behavioral health, even though we need to be proactive, is one that as the hospital itself, we haven't been as proactive as we could.
And I get it. It's hard because, there's places that you can be nimble in, and there's places that you're more restricted, right? But what I appreciate though is, I'm hearing a lot of aspiration with a purpose though. I mean, and I want to reward you and commend you for that because that's what you want. It's easy to get complacent and just say we have to keep going through the motions, and we'd probably get by. But I think Napa just doesn't want to get by. It's like, we want to be damn great where we can.
We're better than that here.
Exactly. So to me, that's what's rewarding. And that's why I'm glad we're having a conversation around health, right? Because it's an integral part to the Napa we all want.
I had a really good, somebody said a quote to me. I can't remember where I read it, who said it, but it's only the mediocre are afraid of accountability. And so many people hear the word accountability, like who's accountable for that? And it sounds like a bad word, but I'm like, let's flip that. Like,
totally.
I'll be accountable for that because I'm not mediocre. Napa's not mediocre. Damn it. We're going to do a great job with that. So every time I hear we're not happy settling for just getting by, I do think that this is a community where that's not how we roll here.
I agree.
As we're getting close to wrapping up, I wanted to ask you, especially to end on a feel-good topic, I would say.
We're going to talk about puppies.
Well, not exactly, but I was going to ask, being a non-parent, you're delivering babies to add to people's families on a regular basis. What's that like? And you've chosen to be in that space in your medical profession.
John, I'm proud of you.
Thank you.
Proud of you for thinking of a good question there.
I'd like the record to show that Alfredo toasted us and then didn't drink his wine.
Oh man, I did. I drank it before, but I'm going to do it again.
That's bad luck. I'm calling him out on that.
Again.
Thank you.
We're still learning. We're just starting this whole
accountability
thing.
There you go.
Yeah.
Don't be afraid
mediocre.
of it.
All right, I'm not.
Don't be mediocre with your wine consumption, Fredo.
So,
I was going to be an orthopedic surgeon. I'll tell you this really quickly about how I even got into this.
I could have used that.
I know, right? I do have a great shoulder replacement guy. My mom fell in Paris and shattered her arm in Paris and had a shoulder replaced. No, in Utah. It's not that far.
Well, no,
we can still go.
Utah, I've never been. So anyway, we'll
best
talk
shoulder
offline.
surgeon ever.
Okay.
However, so I was a gymnast. I've had shoulder surgery. I've had wrist surgery. I wanted to be an orthopedic surgeon. All my rotations in med school were in ortho and ortho trauma. And I was so mad that OBGYN was a core rotation that you had to do. I was like, that's gross.
It's a waste of my time.
It's gross. People are perverts.
Yeah.
I don't want to do that. They made us watch a video the day before on our very first day of a baby being born. And I had to leave and go to the bathroom and be like, oh my gosh, I'm going to pass out. This is so gross. And then I get on my rotation. My first one, it's on labor and delivery. And we do 7 a.m. to 7 p.m. shifts or 7 p. to 7 a. So you switch off after the week and do 12 hours. And it was, I think, my second day or first day. It was my first clinical rotation other than psychiatry. So really my first taking care of patients rotation. And this woman had come in that had tried to get pregnant forever and couldn't. So she'd adopted and fostered and just a lovely human being. And then she and her husband kind of they'd tried IVF, couldn't get pregnant. Then she got pregnant after they'd given up, just been fostering and adopting. So this was their miracle baby. And I'd admitted her and done her history and physical, a little paperwork to get her started and then checked on her throughout the day. And then I got called down to the ER to tag along with a resident to go see something in the ER. And they called my phone and they said, she's complete and pushing. but she's just about ready to have the baby and she's refusing to push until you get back up here. And at first I was like, oh, because I was trying to dodge it, not have to deliver any babies. But I went, and she was such a wonderful human being. So I went up there, and when I got there, she started to push, and she wanted me to deliver the baby. So that was the very first baby I delivered. And it was so amazing. And everyone was crying, and I was crying. And I was like, she let a third-year med student that never delivered a baby before deliver her miracle baby. And she had her foster kids and adopted kids there. So that was where I'm like, okay, this is not a job for perverts. This is so special in people's lives. Yeah, but it really is a special moment. And sometimes at 2 a.m, at this point, I've delivered well over 1,000. I stopped keeping track at 1,000 babies, and that was several years ago. And so sometimes it's like, okay, going in and getting it done. But there's always that taking a step back. And I'm glad my first one was so special with her, because I'm like, this is such a big deal for people.
About it right now. Yeah.
Yeah,
That's awesome.
23 years ago. I hate to admit, maybe more actually.
We don't have to add.
No, we don't keep. You can take that out.
Well, I sound like a cartoon character and I look young, so sometimes it is nice for people to know I do have some experience at what I'm doing. But I was like, oh, that was a really long time ago. That kid is like almost able to rent a car.
Yeah.
Well, you can just have your mask on and nobody would notice how young you look. Well,
that's awesome.
That is amazing. And so that just changed your focus forever.
It did. And it's why I still take calls. So it's not my day job anymore. Now I have all the other jobs. I call them jobs because then it doesn't sound as bad to have to do all the things. But when I take call, I take backup calls. So I go in mostly for surgery and C-sections. Every once in a while, if they're really busy, I'll go do a normal delivery. But it's having that hands-on care with patients so that I can remember why the decisions we make at the other levels of my job, why that matters so much. Is at 2 a.m, I'm still going in and being like, this is why it's important.
Yeah. And you're the first physician, right, to be in this role at Providence.
Yeah, the first woman since the nuns and the only doctor that's done it.
So that's an amazing perspective you bring.
At the Queen, yeah.
Well done.
Thank you.
Awesome.
Cheers to that. And
cheers.
Make sure you guys drink your wine.
Yes.
Accountability, John.
All right, John. I felt like we were inadequate being in there with a doctor, John, and her titles. And
that's just one of her titles.
But we could call Amy because we've known her. But it was a topic that I actually wanted to get into, John. And she's so easy to talk with, and she really humanizes the profession of being in the medical field and being a doctor. So I thought it was fascinating.
And also the first female chief administrative officer, chief medical officer, first doctor to be in charge of Providence Queen of the Valley Medical Center. We've talked about wanting to bring people in that have expert knowledge and perspective, and that's exactly what Amy did today, and really helped us understand more about what goes on in the delivery of healthcare.
And I remember when we were getting our ass kicked around COVID, right? About, hospitals not having capacity and then manipulating the nursing ratios. But she told us what they did. They had to go to the state and try to get exemptions. They did it. Like, that's the behind the scenes stuff that happens. And I hope those that were spreading conspiracy theories or questioning, they hear that and they say, you know what, maybe I was wrong. Because I get the doubt, John. We heard the doubt, but just like we in office were navigating this unknown territory, they were doing the same thing, right? And we were super critical of some of our health professionals.
They were putting literally their lives on the line to serve people. As we were in office and trying to navigate this from the policy perspective, they were providing life-saving care for people they don't know.
And some would say that's their job, but it's a choice they make in that moment to put their lives online, to your point, right? What I also enjoyed, though, is how she acknowledges that they don't have all the answers, right? When we talked about, some of the challenges around healthcare funding in this administration and how it might lead to consolidation or mergers, I think everything has to be on the table. And the fact that you have someone like her in her position saying, yeah, we got to be open and honest around what it means if we want to sustain these outcomes, right? I think she did that very well. And I think Napa County is lucky to have someone like her leading a healthcare system.
It's really impressive. And I feel better having talked to her about this, that I understand the challenges a little bit more. This is not like going to the circus and just ordering a bag of peanuts.
John, I don't know what you mean by that, but anything around a circus does not belong in healthcare, John. Two different things. but I'm gonna make sure that I get you a bag of peanuts for all the holidays. Cheers.